Good evening and welcome to the 10th edition of AIG COVID International Conversations. Every week on Tuesday, we have a conversation with one international expert who is involved with COVID work in any part of the world, where now this is of course pandemic, every country is involved. We generally have been fortunate to have some of the top leaders in this area in the world talking to us, talking to the Indian physicians and Southeast Asian physicians. This evening, I am very glad that we have again one of the topmost endoscopists in England, a leader in this field, Professor Edward Despott. Ed Despott is working at the Royal Free Hospital in London, NHS Foundation Trust, and is an honorary senior lecturer at the University College London. He has a special interest in, of course, small bowel diseases, and he's been to India already. He's demonstrated at one of our national conferences. Ed is not only a fantastic demonstrator, but an outstanding researcher. He's published widely, and of course, his wisdom is what we need today. Ed, thank you for coming. We have already over 3,000 physicians and gastroenterologists from all over India and Southeast Asia who are watching you now, and we are looking eagerly forward to listening to what you say. Thank you, Ed. Thank you for being here.
Thank you. Thank you so much, Nagi. Thank you. It is a huge honor and a pleasure to be with you all. Friends in India, but from all over the world as well. So really, really thank you. And I'm going to share my screen with you just now. So I'll start my slideshow. Can you see it there, Nagi?
Yeah, we can see it. Yeah.
Fantastic. Let me start my slideshow from the beginning. Okay, so this is it. This is the 10th AIG COVID update, and I'm going to be reporting about how the UK is preparing for a comeback. As you know, London was one of the hardest hit, the UK especially, but London was the epicenter, hardest hit areas in the world, and I'll share with you our experience and then talk about how we're trying to come back. These are my declarations. So an outline of my talk, I'll talk about the impact, both international and national, and I'll include the UK's response timeline to that because people question it. And of course, with the retrospective scope, it's very easy to, criticize, judge, etc. But when you're in the thick of it, one has to act fast. And then, of course, there will be time to learn from the effects of decisions. I'll talk about how it's hit us on the front line on a daily practice basis, day-to-day practice, and then we'll start talking about how we're easing lockdown and the gentle recovery and comeback, and then I'll summarize. So the impact. Interestingly, I had a very good feeling about this year. Number one, 20 is my number. I was born on the 20th, and it's a lovely number, 2020. We've got the Olympics coming. So everyone had a lot of high hopes, and New Year's Eve welcomed this year fantastically, and very rapidly this year seems to have vanished. It's the gap year, and our lives have been flipped completely upside down. Why? Because of a minuscule, invisible, tiny, little thing called the SARS-CoV-2 virus, which, as we all know, has caused this monstrous pandemic of COVID-19. And this is a nasty virus. It is a virus that spreads very rapidly. So in a matter of months, the whole world was one big ball of contagion. Look at it spreading like crazy and everywhere. And it's locked down the world in a way that we haven't seen, at least in our time. So literally, it has caused tremendous havoc. And apart from infecting over 6.3 million people as of yesterday, and of course numbers keep going up, it's sadly a very fatal virus with over 376,000 deaths. And as you all know, the UK has been hit very hard, with London being the epicenter, and we've had over 270,000 infections with a mortality rate, or mortality rather, of over 39,000 and climbing, which puts us in the unenviable position of second in the world for the deaths occurred, and also for the death rate quite high as well per million. So, although South American countries like Brazil and Mexico are sadly climbing up, it's become the new global epicenter now, South America. The UK is still really reeling from this, disaster. And the impact has been direct, so the obvious direct morbidity and mortality, with gross restrictions of liberties and freedom, but also indirect, and we should start focusing a bit more on these, I think. The psychosocial, so isolation, separation from loved ones, the fear and the impact on our mental health, depression, and the like. Of course, we have to now start picking up the pieces in terms of indirect morbidity and mortality, which may be even greater than the direct effect of the viruses. So these are the cancers that have been brewing in the community and delaying coming to hospital and then coming a bit too late, or possibly heart disease. There was a spike in mortality from heart disease, stroke, and several other non-COVID conditions. And of course, the financial and economic impact, which is very obvious, both when we're in the peak of it, but also now coming out of it. So I'll talk about our response timeline. So as it started in December 2019 in Wuhan, China, the cases started hitting everywhere, and ours were reported in late January 2020. Rapidly, by late February, we've had the first case of local transmission. And as a result of this, while watching things on the horizon, the UK government came up with a plan which was published on the 3rd of March, which initially had 4 phases: contain, delay, research, and mitigate. And although one can look back with a retrospectoscope and judge that this was possibly a bit too slow to react, one has to understand that we were very new to this virus. The whole world was learning. And also, one had to balance everything. It's not just about the disease itself, it's about the impact, the psychosocial impact, as I talked about, and also economic. So, very, very complex decision-making structure. We started ramping up. So on the 15th of March, the government advised self-isolation for over 70-year-olds, and a day later, there was a restriction of non-essential travel. And on the 20th of March, things started getting ramped up even more. Closure of pubs, cafes, restaurants, bars, and gyms. Why? Because of this paper. This was a report that was published online and led to the government by Imperial College, led by Professor Ferguson. And this work group modeled that if we had to stay on the previous course of action through those 4 steps, we were going to face a tremendous catastrophe with huge overwhelming of resources of the NHS, ICU capacity, and an excess mortality which would hover around 250,000 death mark in one of the scenarios. So this really, really made us shift gear quite rapidly. So the country went into full lockdown on the 23rd of March, and the new slogan or motto to our public was stay home, protect the NHS from overwhelming its capacity, and save lives. And there was also an emergency legislation which immediately followed that, the Coronavirus Act, which gave powers for enforcement. So, heavy fines and policing and ensuring that people were actually following this much needed lockdown. In parallel, there was a huge ramp up of trying to expand the intensive care capacity by securing ventilators. Companies in the UK shifting gear to manufacture their own ventilators, including big companies like Dyson, but also an expansion of capacity through the building of field hospitals, which essentially was conversion of existing large sites such as the Excel, which is a huge exhibition centre. Maggie has been there, I think, for London 20 2009, as you remember, we had the Gastro conference here from all over the world, and this is huge in the center, and it was rapidly, in 10 days, converted into a 4,000 bed hospital. Fortunately, we haven't really needed to use it, but it's there modeled now to be able to cope with a potential second surge. And not only in London was this happening, we've had Nightingale hospitals built up all around the country, a total of 7, to expand this much needed capacity. And this was built in time to deal with the peak, although we didn't really use it that much. And the peak hit us on the 10th of April here in the UK, and it was a staggering 8,681 cases in a single day, and of course with a mirrored mortality. And during that time also our Prime Minister got sick with COVID and was admitted for a few days on the intensive care unit. Fortunately, he's made a recovery. He was one of the lucky ones who made a recovery despite admission to intensive care. It really hit our daily practice very hard, and all elective work was stopped in parallel to the guidance of lockdown, and we switched to doing telephone clinics from face-to-face clinics, but only for urgent cases only. And also there was much redeployment of our staff, all to face this new huge influx of patients with COVID-19. And in order to deal with this, we restructured in our hospital at least into mega COVID firms to be able to cover the hospital 24/7 and restructuring wards into COVID wards. And there was a point in time when our hospital had 85% of the cases were COVID. And the hospital is about 800 beds, so it's massive. Huh? Endoscopy mirrored this, so we automatically switched to doing inpatient emergencies, so just GI bleeds and food bolus obstruction removal or EOCP for affected obstructive ducts. And super urgent cases, for example, dysphagic patients were in the community coming in with esophageal cancer, admitting them to do them rapidly. But it was literally a skeleton shadow of what we used to do. Of course, all this in full PPE, which adds layers to the whole drama of the scenario. This is us in the peak of the pandemic. This is my fellow, Dr. Scanlon, and that's me. And you can see it's more like a screenshot from a movie from the space station rather than an endoscopy unit in London. So literally palpable horrors. And of course, PPE was becoming a very scarce resource, and in order to keep up with the much needed face shields, we started making our own, and we've also published this for others to use. So using an acetate sheet and a piece of foam and an elastic band, we quickly started constructing these face shields. Fortunately, we didn't need to construct any of them because supplies were ramped up in 2 companies, but this is useful and it's very cheap. And the Royal Free, our hospital, was...
Ed, can you, Ed, your voice is trailing off a little. Can you get closer to the laptop? Probably you're a little far away.
Of course. Can you hear me, Nagy? Is this better?
Yeah, this is better, much better. Yeah,
fantastic. Thank you. So the Royal Free was one of the hardest hit hospitals, one of the first to be hit in central London. And because of this, there was a documentary that aired recently on the BBC, on BBC Two, which reflected our story and well chronicalized it. And you can, I think, watch this on the internet. I think it makes for some sobering watching on how hard London was hit. There was a point in time when our hospital, which is quite well seasoned, was practically running out of oxygen, and we had to install new tanks. That's just one example of how hard it was hit. I must say that I'm proud of how we handled it in our hospital, especially because our mortality rate on ITU was around 26%, which is much better than what was being seen elsewhere. I think this for ITU it was about 50 to 60% in mortality. So we managed to cope quite well with this, and I'm proud of our hospital and its management. So passing through the peak, through the horrors of the peak, now we're trying to ease lockdown and moving into a gentle recovery. And the reason for this is because we are very much concerned about what is happening in the community, these cancers that are brewing there and other diseases, of course. So the government on the 10th of May announced how we are going to start easing lockdown, and of course it's all very much dependent on the reproductive or spread of the virus, the R value, and when it's 1 or above, the infection is spreading quite rapidly through the community. But if it falls below 1, then we can start taking some steps to adjust. And of course, the step 1 would be outdoors and maintaining still social distancing, but relaxing a bit on how much one can exercise. And then step 2, which is what we're moving into now, is the opening of schools. I think step 3 is going to be quite further down the line, but that would include opening things like restaurants and pubs, etc., but still with social distancing in place. And of course, for us to start relaxing the measures, we have to constantly look at the 4 tests. So we have to always ensure that we have enough capacity in the NHS to be able to cope with a further surge. And that has been done through restructuring of our hospitals, through opening up of these new field hospitals to make sure that we have enough ventilators and being very vigilant. Of course, we need to monitor the R value to make sure that this is not spreading rapidly in the community, and very much dependent on testing. And initially testing in the UK was a bit of a problem, but now fortunately we're ramping up testing very rapidly, and we're trying to hit a goal of about 200,000 tests per day, and this will allow us to test and contact trace and contain any clusters, which will be, I think, one of the key measures to guiding ease of lockdown vis-a-vis before we get any very effective antiviral therapies and possibly a vaccine. And of course, this is a dynamic process. So as soon as we see that things are moving in the wrong direction, one has to re-implement measures in order to not allow the pandemic or the epidemic in the UK to actually fall back into a rampant catastrophe. So the new slogan or advice is stay alert, control the virus and save lives. And stay alert, although it may sound vague, is very much dependent on these levels of alertness. So essentially monitoring the R value and the things I've spoken about, and we're currently hovering around here. As soon as we hit level 5 or move in the wrong direction, then of course we have to stick the old measures into place and impose full lockdown. But gently we are easing this, because our R value, at least in London, has dropped below 1, and it hovers around the 0.8 or 0.9 mark, still teetering on the edge, but at least less than 1. And as a mirror to what was happening nationally, our British Society of Gastroenterology produced a set of guidance with our Vice President for Endoscopy leading the way, Ian Penman, along with Professor Rees, colleagues from Newcastle. And in essence, I'll summarize these because you'll get a flavor of what is happening in endoscopy. And although I understand that some of our viewers are not endoscopists or gastroenterologists or general physicians, this will give you a flavor of what's happening generally in medicine. So of course these guidelines are very much based on consensus, but also on the available evidence, but will be adjusted according to the evidence as it comes through. And the rationale behind them is to prevent any further delays in diagnosis of other conditions, because this of course poses a risk of serious harm. Patients will die from undiagnosed cancers or other things which are non-COVID. And the aim is to at least recover 75% of our previous norm. Remember that there are a lot of things holding us back, not just relating to testing and restructuring of our unit, but also the very fact that with PPE on board, with personal protective equipment, and with time delays in procedures and allowing the room air to settle, etc., this will slow things down quite rapidly. So I'll guide you through that. Of course, the recovery has to be planned and phased, And of course, different scenarios will apply at different stages. And this mirrors the national guidance. And of course, subject to changes as per new evidence and of course, as first stage of pandemic. So the plan is to redeploy our staff back to the endoscopy unit from other places such as the intensive care. We have to make sure that we have extra time and space for procedures, and that of course pre-procedure COVID testing of patients happens, and having COVID minimized facilities like green areas or green facilities may even help us to minimize the levels of PPE that we will apply. In places like a hospital where there are mixed zones, so we call our hospital a blue site now. In the UK, we've labeled blue as COVID rich or COVID heavy, and green as COVID sparse or COVID free, or aspirating to be COVID free. And of course, where there is the potential for an increased risk of exposure to COVID, a strict patient flow is very, very important, and separating of patients from those who are likely to have the infection is important, because as you know from the literature and from experience, not just in the UK, but of course elsewhere in the world, some of these COVID infections happen in hospitals. So patients come in for something else and then get infected while they're in the hospital. So separation is important. And of course, ensuring that supplies of PPE are ever present. This is the flow chart which depicts the guidance in summary, but I will zoom in. So this is the Scots telephone screen questionnaire. So before anyone is considered for an endoscopy, our admin staff call the patients up, ensuring that they don't have any of these features of COVID or have been in contact with COVID over the last few days, so symptoms, etc. And if, of course, anyone scores into this Scots criteria, they, unless of course this is going to be a life-saving procedure, the procedure would be considered to be postponed. And then after answering the Scots questionnaire, we move into testing. So if no testing is available in centers where no testing is available, of course all endoscopies have to be considered. The patients are COVID positive and full PPE should be worn. In scenario 2, when testing is available, of course, the test would be done about 1 to 3 days, depending on the type of test used. There are some rapid tests, but most of the time we're using the reverse transcriptase PCR, which takes about 2 days to come through the result of. If it's positive, we have to consider postponing, and if we can't postpone, then of course, if it's a positive result, all procedures would be done with full PPE level 2, and I'll talk about what that means a bit later. If the swab is negative, then there is some leeway regarding PPE. So although there is debate about it, the lower GI procedure is considered to be non-aerosol generating, and an upper GI is considered to be aerosol generating. So upper GI procedures or combined procedures are done with full PPE. And there is a bit of leeway relating to colonoscopy and flexible sigmoidoscopy. And of course, if any doubt, we go back to rescheduling the procedures and then diving back into the questionnaire. And after the procedures, it's important that we screen our patients through a telephone call at 7 and 14 days, just to make sure that they haven't developed any COVID symptoms for us to be able to contact trace and treat accordingly. And this is the summary, which is in line with the Asian Pacific and also the European guidance for assessment with that questionnaire, testing where possible, and of course PPE, level of PPE depending on the above. And this is the European guidance led by Professor Granek and Mario Ribeiro, which mirrors our flowchart and also guides a bit more about what level of PPE is used. So this is level 1. So the only main difference is the surgical mask vis-a-vis the FFP3 or FFP2 mask, and in some instances the gown, okay, the type of gown used. The other things are identical, so we should all be wearing face shields and aprons if possible. And this is a pictorial diagram, so in essence it's mostly the type of mask. We prefer to still use full covered gowns regardless, and many a time we are still using FFP3 masks if they are available. It's important when talking about PPE that we also mention the importance of properly donning and doffing. The highest risk is doffing. So if you are in contact with any surface of your PPE that may be contaminated while you're taking it off, you're putting yourself at risk. So it's critical that people do not touch the PPE surfaces that they've been wearing, and they decontaminate their hands at every stage of the doffing procedure. And this should be done with supervision from a buddy. Another point to consider is the unit environment. So as you know, most of the time COVID is spread through droplets and aerosols, but also on surfaces. And the rooms should be very, very well cleaned. But of course, the air in the environment can stay contaminated for hours if there is an aerosol generating procedure. And although it is ideal that we do these in negative pressure rooms, many a time it is not possible to have these available, and many centers don't. So although we have seen other types of equipment being developed for containment of aerosols, for example, a Perspex box and also a double chamber of plastic bags, these have all been published in Video GIE recently. Ourselves have thought of doing something very simple, and this includes the use of a double surgical mask with a slit, because as you know, surgical mask, the rationale behind it is to stop this shotgun effect. Aerosols, when one coughs, are sprayed in a shotgun manner, and if you have a barrier here, you prevent or at least mitigate spread of droplets. And that is why the surgical mask worn in public may help to prevent spread to others, not necessarily prevent infection of the person wearing it, but it is mostly there to protect the others. And we thought of it, and we came up with the idea of putting two surgical masks on top of each other, taping them along, and then making a micro slit less than 1.2 centimeters for passage of the scope. And as you can see in this diagram, the two masks act as a curtain, and although it's probably not entirely airtight here, of course, it mitigates the risk of having a lot of aerosols in the room, and this is us doing it at antegrade double balloon endoscopy. Other special points, I can't stress enough the flow through the unit of patients and allowing for space between patients in recovery and the waiting areas. So we recover patients on alternate beds, and if there is a potential COVID positive patient, we try to isolate them in a separate recovery room. And of course, surgical masks for patients for the reasons I've mentioned above. And if we are working in a blue site like my big hospital, then we try to split sessions whereby inpatients are done in the afternoon and outpatients are done in the morning, so that we won't be mixing. Because although the risk, I suspect now at this stage, is still relatively small, and there is still a theoretical risk of false negative swab tests. Remember that swabbing is very much the sensitivity of swabbing is very much dependent on the swabbing technique, but also it has been shown that it can be the lowest sensitivity is about 70%, so we have to be careful. So I think it's important to try to develop clean sites, and Rule 3, like many other hospitals in the UK, has been moving towards the development of clean sites. We've got a special hospital for that called Chase Farm, which is an outpatient hospital, doesn't have inpatients. We're trying to establish that as a green site. And of course, if we are establishing green sites, it makes sense to try to avoid the rotation of staff from sites that are dealing with COVID to sites which don't have it. And although we can test on a regular basis, it makes sense to try to reduce crossing over. And we've also split into the independent sector, at least here in London, and the independent sector has been taken over temporarily by the NHS, and this has allowed us to expand the capacity and possibly make testing and procedures more rapid. National strategies which are being mirrored by the government, so the aim is to have over 200,000 reverse transcriptase PCR tests per day. There's going to be a phased introduction of the highly accurate antibody test by Roche. and also the development of an app which has already been tested and is going to roll out very soon, which would allow vigilant contact tracing and alert you to self-isolate or that you have potentially been in contact. Other thoughts? Will there be a second surge? Who knows? Logic says that there very well could be. If we look at the influenza pandemic that is constantly quoted from 1918, there was indeed a second surge and possibly a third surge, and this tends to happen when measures are relaxed. So we're at the moment at a very dangerous or potentially dangerous crossroad here. I'm hoping that with all steps in place, we'll be able to detect a surge in cases and stem it in the bud, so it won't be half as bad as what we've seen before. But there is always a risk that this can happen, and there are schools of thought which say that the virus may actually mutate into a less virulent form. I think it's still early days to actually say that, and we hope that somehow, somewhere, a vaccine or proper antiviral therapy will become available. So in summary, Maggie, I think, and I hope I have shown you that COVID-19 has hit the UK, especially London, very, very hard indeed. There was a severe direct and indirect impact, as has happened in many places around the world. Fortunately, our R value is on the downscale now, so we're easing into a gentle recovery and relaxing of measures. In terms of endoscopy recovery, but this of course echoes things that happen in general medicine and other places, is going to be slow and dependent on testing. Personal protective equipment still remains essential, especially visors and FFP3 masks. And the idea is to try to have relatively COVID-sparse sites with the acknowledgement that there are sites which are going to be slightly more burdened with COVID. And of course, I think the general ease of lockdown is going to be dependent on massive test and trace programs. And hopefully, in time, this too shall pass, Nagy, and while we live in nostalgia for our normal recent past, we shall continue to hope for a happier, safer, and brighter future. And hopefully, this won't be too far away, allowing us to have our upside-down world being returned to normal. This is our hospital as seen from the beautiful Hampstead Heath in London. I'd like to thank our team who have been really, really tremendous during this effort. Our newcomers, Dr. Alexander Stamnos and Dr. Sio Shaki, and of course our Japanese colleagues who have a strong collaboration with the world field, Professor Yamamoto and his team from Jichi Medical University. And although Nagy, I know how fond you are of our masterclass, we've had to do something different this year, so we won't have it in person, but we certainly shall do something for you. And Alberto says, I as well, from the endoscopy unit. So thank you.
Thank you, Ed, for that brilliant lecture. I think you covered both endoscopy, non-endoscopies extremely broadly and told us what's happening there. We got the feel and the flavor of what's happening in UK. Over 4,000 physicians have actually watched this program, so there's a lot of questions coming in. We'll try and keep it limited to certain, because I know the time is going to be an issue. First of all, the first question they're asking is, what about the rate of healthcare workers being infected in UK? Is it a large number? Is it decreasing because of all the precautions you're taking? Can you tell us about that?
Yes, thank you, Nagy. That has been very, very hot on the press. It has caused us grave concern. Sadly, we are one of the highest ranking countries in terms of mortality and morbidity of colleagues. I can't give you an exact number, but it's certainly among the highest, if not the highest in the world. And I think this is reflective mostly of the shortage of personal protective equipment, and potentially also the mixed in London, and you know that certain ethnicities are much more prone to COVID, and we're trying to understand why that is, but it has to do with immunology and the immune response to it. I know that for certain in our hospital we almost lost a couple of colleagues to COVID. Fortunately, there was a good recovery, and this really touched our hearts. But we have seen losses, yes. So I think that with this in mind, and really the securing of full PPE and making it available to all, especially if a second surge hits, is going to be something that we have learned from, sadly, bitterly.
Thank you, Ed. In fact, there's a question from Dr. Jimmy from Lima in Peru. I don't know, people from all over the world are watching this. So Dr. Jimmy from Lima in Peru wants to know that according to the British experience treating these cases, are there any different drugs at different stages? Any experience from UK that you would suggest would help rest of us?
The different stages, as in,
yeah, I think they say in the mild case, would you use drugs? If it's a moderate or severe case, is there a role for remdesivir to be used? Or we've heard, I don't know whether it's rumors, but we've heard that Boris Johnson, for example, got convalescent serum given to him and recovered because of this.
Yes, so thank you, Nagi. I understand, and I thank the doctor from Peru for this lovely question. One of our fellows actually comes from Peru, Dr. Rosillo. Exactly, so it's interesting. It's all very global, very nice. But to answer your question, we are undertaking several studies, actively participating here in the UK, international studies, our hospital especially. And yes, antivirals are being used with good success. I know for certain that we've had some very nice stories with shortening of the length of the actual duration of the severity of disease, patients making a good turnaround. I think that proning patients early has also helped on the ITU, and we are also studying the use of convalescent plasma. So yes, of course, these are mostly reserved for patients who are on the brink of going to the ITU or on ITU, and this is the experience that we have. But of course, this may be rolled out to all cases. But at the moment, it's all in a clinical trial context.
Okay, thank you. Dr. Sanjay Jain from India wants to know: are you seeing cases of COVID with only diarrhea coming in predominantly as diarrhea as a manifestations? And when this happens, is prognosis worse in these patients?
Thank you. So yes, we have seen cases coming in with atypical symptoms, all right. So a bit of malaise and general fatigue followed by cramping, abdominal pain, a bit of diarrhea. I don't think we can actually say that the prognosis is poorer for these patients. The viral load would certainly possibly be higher, but I can't tell you for certain that this definitely indicates a poor prognosis. What we know that indicates a poor prognosis is, of course, the association of comorbidities, being elderly, male with of course, certain ethnicities faring worse. Obesity seems to have a big role to play in this, and also what happens in terms of the response, because there is the direct viral response, which is dangerous in some, and we have to understand why some people are more prone to this than others, but also how the virus, how the body reacts to the virus, and many a time the inflammatory response is just as critical. So yes, we have seen cases with diarrhea, predominant COVID, and possibly with worse disease, but I can't tell you that the prognosis is definitely worse in these for certain.
Thank you. There's another question which is coming in from Dr. Trideep Chatterjee from West Bengal. He wants to know, I think this is what all of us are anxiously waiting for, to know what's happening regarding the Oxford vaccine. At least the newspapers here, the media is covering a lot on the Oxford vaccine, giving us hope that sometime end of the year it will be there and that we'll all be protected. So anything you can tell us about that?
Thank you. That's a very good question. Everyone is really hopeful about the vaccine. There is, of course, this famous program in Oxford, but there are also other vaccine programs running in parallel. And fortunately, we live in an era where knowledge is shared very easily and may impact on how well vaccination may become effective. As regards to its availability, We get glimmers of hope, but then of course these hopes get shattered very rapidly, because a vaccine doesn't just have to be made, but it has to be effective, and it's all going to be dependent on testing, not just animal testing, but also on testing in public, and we'll see whether there is actually going to be direct benefit. There are still a lot of question marks about vaccines, so although we are going to be hopeful, I think we have to temper that hope with some realism, and this is why the measures that I've described earlier are going to remain very, very important. We can't assume that the vaccine will be available anytime soon, because I think we'd be shooting ourselves in the foot.
Thank you, Ed. Professor Kumar Ratnesh from India wants to know that how is it that some of the best hospitals in the West, in Europe and US are there, and yet the mortality rate in the West is much, much higher than, say, in situations like in India or in other third world countries where there's not enough infrastructure. So this looks very odd that you have the best hospitals, yet you have the highest mortality.
Thank you. Very relevant question. I think that is a multifactorial answer. Yes, sadly, we have suffered tremendously, the UK, Italy, Spain, and especially the United States, but we're also seeing South America now beginning to suffer greatly. Why? Again, multifactorial. So I think it has to do with measures and the implementation of measures, the time scale of that. I think it has also to do with the density of population in cities like London, New York, for example, which was the epicenter of the States, as you've heard Amrita Sethi tell you, and population density. I'm not sure whether it also has to do with culture, the ways that people perceive risk to the virus, methods of public transport, for example, availability to air travel. So I think these things all play a role. As regards to mortality within the hospitals, I think despite the fact that we do have some of the best equipped hospitals in the world, if hospitals are going to be overwhelmed, and it's easy to overwhelm a hospital, and things run out, things like PPE run out, etc., then of course you're going to have a reflection of that in terms of mortality. In my hospital, we haven't seen that to be such a huge effect. As I told you, we were lucky that our ITU prone patients and took certain measures which have fortunately reduced overall mortality vis-a-vis other centers. But I think it is a multifactorial, and we'll only know the answers to these questions in any real certainty with time.
I agree, and I think in India we believe that the lower age group, more people in the rural areas, widespread, and probably some local innate immunity which is sort of different, or some factors seem to be protecting us, because our mortality is only 2% now, 2.5.
Yes,
there's another interesting question which is coming in from Brazil. I didn't realize people all over the world were watching. This is Dr. Lix Oliveira, and he asks, he asks, when should we return to screening program for preventing CRC? When should screening program start? Yeah.
Hi Lix, greetings from London. Thank you for watching. It's a very different scenario to when we were in Rio de Janeiro for Indo 2020, that's for sure, Lix. So anyway, back to your question, screening. I think one has to prioritize. So at the moment, at least in London, in the UK, we have a huge backlog of what we call 2-week waiters. So these are patients with symptoms suspicious of cancer. Usually we would have fast-tracked them to an endoscopy, and at the moment we're still trying to catch up with that backlog. So I think we have to stratify according to risk, the symptomatic patients first. But of course, if we leave screening to run on the side, then of course we're going to have an eventual negative consequence of that as well. So I think when we can open up, it would be mostly with the QFIT tests and the non-invasive screening methods, until we are in a position to be able to start offering endoscopy-based screening tests. Of course, we have to explore non-invasive things apart from the QFIT, such as CT colonography, and capsule, albeit they're not the gold standard. This is a very different scenario to what we were in even a year ago, and I think that we have to adapt accordingly. But the priority goes to symptomatic patients who are waiting.
Thank you. There's another interesting question from Debajit Barua from eastern part of India. He says actually this is again circulating a lot in media, and there's some evidence, some scientific evidence suggests that the virus is losing its patency, and as we are going forward the virus seems to be losing its virulence, especially Italian report suggested. What do you think? What's your opinion?
So, yeah, there has been some evidence coming through from Lombardy about this. Viruses mutate in different ways, and one of the biggest questions in epidemiology is how do pandemics fizzle out so rapidly, in a way as if they came rapidly and then they fizzle out rapidly, and it has to do with many factors, both immunity of the population but also possibly viral dynamics. And coronaviruses do mutate for sure, in a different way to what the influenza viruses do, hence why we cannot say that this is a flu, because it's certainly a different kettle of fish. But viruses can sometimes mutate to become less virulent rather than more virulent, and hopefully this is the case. They might even become less contagious. I'm no virologist, I'm not an expert in this, and I'm not an epidemiologist. But of course, there is some strength to the argument, and I'm hoping that there is some truth to the matter, because if that is the case, it will help us in the effort to control this dreadful disease.
Yeah. So we have another question from Dr. Masifik Hemad from Bangladesh. He says that he became COVID positive and is recovered now, but he fears that he can get a reinfection when he goes back to the hospital. What do you think are chances of reinfection?
Right. That is the million-dollar question. No one knows really whether the antibodies do convey a lasting immunity. But looking at what we have in terms of other diseases, although coronaviruses tend to be a strange kettle of fish, because we don't really have a vaccine for coronavirus to date, and we know for certain that we can potentially have reinfections with coronaviruses of the common cold. It makes sense that if it is not complete immunity that is confirmed by the antibodies, there might be some protection, at least in the first few months after infection. So that is the hope, and that is the working model. And I think it is, although an assumption, it does make sense, but there is no evidence about it. It hasn't been studied in depth, and as I say, I'm not an immunology expert, but there is some logic to indicating that there is some protection. The answer to your question, sir, from Bangladesh would be, if you are going to go into a COVID-rich environment, you should take every precaution like everyone else and wear full PPE, because one cannot assume that the immunity is actually confirmed by antibodies until we have strong data to support it.
Thank you. There's Anil Boralkar from India asking about hydroxychloroquines. The reason is that in India, the ICMR has suggested, Indian Council of Medical Research, that all healthcare workers can be on prophylactic hydroxychloroquine 2 tablets once a week, and this probably protects them. And there's one study, a randomized study which they did in one of the institutes to show that this is protective. So are you taking hydroxychloroquine in UK as a protection for healthcare workers, or is it?
No. Thank you. It's a relevant question, and there has been a lot of talk about hydroxychloroquine, as you know, from the States. Even President Trump was advocating its use. But although there were some initial indicators that this might be protective, these were very small studies. And when larger studies were done, as you know from the literature, the evidence was put into doubt, and there was even an association with increased mortality in patients taking hydroxychloroquine. So the answer to your question is no, we do not take hydroxychloroquine, and we do not advocate it for prophylactic or general use because the evidence is not there. If anything, there is evidence to show that it might be harmful.
Yeah, I think the recent Lancet article seems to put that to
So-
rest. Although in India still, the Indian Council of Medical Research is advocating it. So some people are still taking.
But Nagi, this is a dynamic picture. As you know, we're still learning about the effects of everything on this. We're learning on the fly. We're literally learning how to walk while walking. So no criticism, but there is the strongest evidence we have, the latest one for sure, is that it probably isn't helpful and it might cause harm.
Yeah. Actually, Ed, there are many questions coming in, but because of lack of time, I'll just take one last one. This is from Dr. Sahu from Orissa in India, and he says, what about recovery? Is there any long-term complications? You see patients are very severe on a ventilator, they recover. Do you think they completely recover, or there's some sequelae long-term?
A nasty disease, Nagi, it's a nasty disease, and it's a bit like Russian roulette. You don't know what you're going to get, okay? You might get an empty chamber and have an asymptomatic infection, but you might be hit by a magnum bullet, which causes devastation, especially if you've got comorbidities or if you're elderly. But we've seen it happen even in relative youngsters, so it is really like Russian roulette. And sadly, there are several reports in the literature. This may have long-term sequelae, especially for patients who have been intubated and have spent a long time on the ITU, because this cytokine storm induces a degree of fibrosis in the lungs, which has indeed its known long-term sequelae of decreased exercise tolerance, shortness of breath, and oxygen dependency. As regards to other effects, we're looking into potential neurological long-term effects. As you know, one of the symptoms that has been described in many a cohort is anosmia, and that indicates that this may have a heavy load on the neurological system. And who knows, we might be even seeing a wave of neurological complications way down the line, like similar to other viruses which have caused, for example, Parkinsonism or damage to the basal ganglia long-term down the line. So the answer is we're still trying to understand, but yes, there are indicators that some individuals may have long-term sequelae.
Yeah, we actually wanted to end here, but the two keen questions, two doctors are very keen that you answer this, and that's the reason why we'll quickly end up after those two. One is Dr. Nageshwar Reddy, and he wants to know regarding this autopsy study showing that there's a lot of coagulation problems in these patients, and use of aspirin and anticoagulants seem to be helpful. What's your experience, or what do you think should be done?
In our hospital, that is a very important question. So we've seen some early in the pandemic, and this was also echoing things that happened in China and Italy. We're seeing some bizarre effects of this virus. Not only was it affecting the lungs, but it was also affecting all sorts of other things. It seemed as if it was attacking the endothelium, and also causing insulin resistance and possibly even attacking the islet cells in the pancreas. So patients with diabetes, for example, and even type 2 diabetics were coming in with DKA. Very and extremely high doses of insulin were required. So bizarre, this was something unique. Another unique thing that was happening was young patients were suddenly dropping dead or getting huge DVTs, or if you scan them, you find a massive pulmonary embolus. And it is now documented and well accepted that this is a virus or a disease that definitely induces procoagulation. It is extremely procoagulant. And we were using treatment dose anticoagulants in ITU, especially in cases where there were other features which may put them at risk. But yes, of course, this is something to be borne in mind. I mean, there are guidelines coming out about this on the use of blood thinning agents in this context.
And finally, this is from Dr. Rajshekhar from Salem, southern part of India. He asked this question whether if you have a patient who is an asymptomatic carrier, you don't detect and he comes for a therapeutic endoscopy procedure, is there an increased risk to the patient in terms of morbidity and mortality?
So, for example, he comes for an ESD and he's COVID positive. I don't think so, Nagi, unless of course you're dealing with a frail patient who has contracted the COVID in the hospital and then subsequently suffers consequences as a result of that. I don't think that we can say that therapeutic procedures put patients at risk. But going back to my presentation, it is critical not to mix patients who are high risk with patients who are low risk. Risks stratify according to age, comorbidities. Try to keep sites clean, wear PPE at all times, test patients, test staff, and try to protect as much as possible, because this is the only way we are going to prevent nosocomial risk both to staff, to patients, and to patients amongst themselves.
Ed, there are actually many more questions coming from all over the world, from Thailand, from Malaysia, from Singapore. Unfortunately, we are out of time. Maybe we should take your time another time just to answer these questions. But I think this is a brilliant lecture. Thank you very much for this outstanding talk and your question answers, which I think we all enjoyed. In fact, we've been enriched by what we learned from you today, and hopefully some of this we can get back into our patient practice, and both the doctors and patients would benefit. Thank you very much, Ed, for this outstanding talk.
Thank you so much, Nadine. All the best to you, your family, and also all the team at the AIG. Thank you.
Thank you. Thank you very much.